Good morning, everybody, and welcome to this webinar. My name is Councillor Hudspeth. I'm the chairman of the Local Government Association Health and Wellbeing Board. I'm also leader of Oxfordshire County Council, and I have to say I am an ex-smoker, but I'm not evangelical about it, so I just have to give you that heads up first of all. First of all, thank you very much for joining us this morning, especially during this busy period for all of us. This event is funded by the Department of Health and Social Care, which will focus on the contribution public health can make to supporting our COVID-19 response and the long-term improvements in population health, especially given what we're seeing with COVID at the moment. Following the government's announcement on the merging of Public Health England, the presentations will highlight the principles that must form the basis of a new public health system and test the system that must deliver against. The presentations will consider in more detail the action required on tobacco control and to reduce the rates of obesity and alcohol abuse. Please note there is a questions section and we'll have that at the end, and it's on the right hand side of your panel. And I'll ask all attendees to log the questions there, and then we have the questions and answers at the end when we'll put to either specific presenters or alternatively all the presenters to answer. One of the things that I must highlight to everybody is that this event is being recorded, and the recording will be distributed along with the follow-up survey after the event. We do have some really good speakers this morning. First of all, it would be Linda Bauld kicking off, then Deborah Arnott, Chair of Schoenberger, Carolyn Shady, and Hazel Cheeseman. So there's going to be a wide variety of views coming across, and I hope that it will stimulate you into asking lots of questions. And as I say, that'll be at the end of all the presentations. First of all, it's my pleasure to introduce Linda Bauld, who's going to talk about the role of public health in building population health resilience. Professor Linda Bauld is the Bruce and John Usher Chair of Public Health at the University of Edinburgh and Director of Spectrum Research Consortium focused on the commercial determinants of health and health inequalities. Linda is going to speak on the role of public health in building population health and resilience and support our recovery from COVID. Linda, over to you. Thank you.
Thank you very much, Ian, and thanks again for your very kind introduction and for chairing this event. So hopefully you can now see my screen. Is that looking okay?
Yeah, that's great.
Wonderful. So I'm just going to speak briefly for 10 minutes to set the scene and try and emphasize why we need to integrate both health improvement and health protection. And I'm going to start by just referring to public health. Everybody joining today knows what that is, but I'll show a slide that I commonly use with medical students to try and show how these things are interlinked. I'll then give you some concrete examples why health improvement is so important, both in relation to people coming into contact with the virus, developing COVID-19 and disease severity, then comment on its importance for recovery, which I think is what today is mostly about, and then the need for comprehensive evidence-based interventions at different levels. So just as a reminder, these are the key elements of public health and they interlink. So health improvement, by which we mean addressing preventable risk factors for disease and also their underlying causes. Health protection, which of course we're now focused on, particularly addressing communicable diseases primarily, although it has other aspects. And then also just the interlinkage with services. So looking at healthcare and wider service improvement for population health. And the two are interlinked because at the moment we're focusing very much on health protection. That's been much of the discussion around Public Health England and its future role in terms of emphasizing those elements. But as everybody knows, non-communicable diseases contribute to far more preventable morbidity and mortality globally. They kill around 15 million people before the age of 70, and that's going to far exceed even the worst projections for COVID-19. And as all of you know, one of the reasons why we, in contrast to some other countries, have been so badly affected by COVID-19 is the burden of NCDs on our population, coupled with long-standing inequalities and decades of underinvestment in public health, as well as specific critiques of our public health response during the pandemic. So to address both the current crisis, which we're still very much in the middle of, and prepare us for future ones, we need better and more sustained attention and investment in public health generally, but health improvement, in my view, in particular. So in relation to why we need to make the case for health improvement to address COVID-19, around 1 in 4 of the population globally has an underlying condition, and I'm going to show you examples from the UK that increase vulnerability to the disease. And also in relation to our most disadvantaged communities in the UK, it's now absolutely clear that it's not a pandemic, it's a syndemic, as the Lancet has said, a co-occurring synergistic pandemic that is interacting with and increasing social and economic inequalities. And this includes in particular the preventable burden of non-communicable diseases, as we'll hear from the other speakers, caused by tobacco use, alcohol, and overweight and obesity. And all 3 of these risk factors cause increased disease severity in terms of underlying conditions from COVID-19, and overweight and obesity on its own is a risk factor, both for infection and for disease severity. So the measures which we've taken quite understandably to address the current crisis have diverted investment and services away from health improvement to health protection. And it's perhaps understandable in the very early chaotic stages of dealing with the pandemic, but overall it's misguided and it neglects the interaction between the two. And just to show you in relation to underlying risk factors, this is the ISERIC Consortium. If you're not familiar with it, I do commend them to you. It's the largest global group. They've repurposed to look at COVID. They have, in this data from the beginning of September, just under 100,000 individuals hospitalized from 562 sites in 42 countries. And you can just see in relation to the underlying risk factors, those admitted to hospital with COVID-19, it's very clear that many of these conditions are tobacco or related, or indeed overweight and obesity as an independent risk factor, and some, including alcohol, also linked to some of these underlying conditions. So that just, I think, brings it home to us. In terms of the mortality challenge, this is a paper from my colleague Jerry McCartney and colleagues, the references at the bottom, just looking at some of the modelling done to deal with pandemic. So we know about the mitigated versus non-mitigated pandemic, the early models from Imperial and others. In terms of reducing life expectancy by about 1/3 in a single year for the population as a whole. And if we'd done nothing, it would have been far greater than that in terms of its impact. But that pales into insignificance with the health consequences of inequality. On life expectancy, those are 6 times greater than even a completely unmitigated pandemic based on the worst case scenario. So COVID-19, which we're experiencing now, is a mortality shock, but it's nowhere near as big as the inequality long emergency. And health improvement, in terms of its underlying response, is about trying to address health inequalities and the health of populations who need support the most. And this finally, just a couple more slides. I don't have time to go into this in detail, but again, another paper I commend to you from my colleagues at Edinburgh, just trying to look at all the unintended consequences of the public health measures that we've taken, not just what happens with COVID itself in terms of direct health impacts, but also the things people have been asked to do in the way their lives are restricted, the mental health impacts, the unemployment consequences, the risk, which we've seen certainly with alcohol, with hazardous and harmful drinkers increasing their consumption during the early months and ongoing in the pandemic, and then some of the other behavioural impacts of the public health measures. So this indirectly attributable morbidity and mortality due to the crisis needs a health improvement response. And I think we're not thinking at the moment enough about that. So what do we need to do? Focus on all of public health, not just health protection, reinvest in key health improvement services and policies, some of which actually could add money to the public purse in terms of fiscal measures, address inequalities and recognize these linkages, focus not just on the national, but importantly on the regional and local infrastructure and responses, and build back better with public health and responsive community services and interventions at the very core of our response to COVID-19. So thank you very much for listening. Just a brief introductory presentation from me. I hope that was useful, and I will stop screen sharing now. Thank you.
Thank you very much indeed, Linda. That's really useful, and particularly, of course, that regional and local issue, which, as you can imagine, as local government, I'm really keen on actually us looking at the local impact and what difference we can make, particularly around inequalities. And I'm sure other speakers will mention that. So don't forget, if you do have any questions, put them in the bar and we'll be coming to them at the end. Right, thank you very much. Next we have Deborah Arnott, tests for a new public health system. Deborah is Chief Executive of ASH and leads the Smoke-Free Action Coalition. Deborah is going to speak on the test for a new public health system following the government's decision to close Public Health England and the future of Public Health England's health improvement functions. Thank you. Over to you, Deborah.
Thank you very much, Ian. Now, I thought I'd shared my screen. Can everyone see my screen?
Yes, we can now.
We can.
Good,
Yeah.
thank you. Let's get it up full screen. First of all, Ian, I'd like to thank you very much for chairing this morning's session. I know how busy local authorities are at the moment, and we very much appreciate your participation and contribution. So I'm going to talk about the tests for a new public health system. And you might wonder why ASH is talking about this. But what happened when the announcement was made in August about public health reorganisation, which focused on health protection, was when we started to look at it, we became very concerned that the government's plans paid insufficient attention to the vital health improvement and other wider functions of Public Health England. And when we started to talk to other organisations, the Obesity Health Alliance, who are presenting this morning, and the Alcohol Health Alliance, to the health charities, to local government and to NHS organisations, we realised that we weren't the only ones who felt this way. And we were asked to coordinate, in the first instance, a joint statement which set out the principles for any new system, including funding and expertise. And that was published early in September and covered and was endorsed by 120 organisations. It then became clear that the government was proposing to publish options sooner rather than later and have final recommendations by the end of this this calendar year. So we moved on to develop a second joint statement, which has already been endorsed by 50 organisations, which sets out the 6 tests that we all believe that a public health system must meet. And what I'd say is that this has been endorsed by a very wide range of organisations, and thanks to Ian and his colleagues on the Community Wellbeing Board, it's been endorsed by the LGA, but also by the Association of Directors of Public Health, Faculty of Public Health, the leading health charities, CRUK, BHF, of course, but also the Richmond Group, Spectrum, which Linda Bauld is director of. So we've got academics working in public health as well as the NHS and the Academy of Medical Royal Colleges. So what are these 6 tests? Well, the first one is sufficient and secure funding to scale up health improvement interventions. We set out, if you look at the statement, we say a bit more in detail, although more work needs doing on that, but the Health Foundation, who've done a lot of work in this area, have also endorsed the statement. They've calculated to make up for the cuts in public health funding since 2015-16 would require 900 million. And then to actually tackle inequalities at local level would be a further 2 billion. And that was prior to the COVID pandemic. Sufficient high quality public health experts in health protection, health improvement and healthcare public health functions is the second test. The third is the commitment and infrastructure to deliver health improvement at national, regional and local level. And we focused on those 3 levels because there is a real risk. One of the options that's been put forward in the policy statement published last week was that everything be devolved to local level. But local authorities are under enormous pressure, and while they play a really important role in public health system leadership at local level, it would be setting them up to fail if they had the entire responsibility for delivering health improvement. So we don't think that's that would be helpful. And the lesson from tobacco control is that the regional level has been extremely important, and Fresh, who are our partners in this, are a good example of how that has worked effectively. A stronger health intelligence function, which supports both health improvement and health protection and underpins accountability. I mean, one of the really important functions of Public Health England, and those of you working in tobacco control will know, on the fingertips function gives you fabulous information at regional, local and national level about the impact of tobacco and smoking. And there is a real risk that that function will be taken on by the National Institute of Health Protection, and that the health improvement function of health intelligence will be weakened or basically handed off to some other place where the system doesn't exist. Improved coordination between the NHS and local government. And we think that's essential going forward. I mean, there are some very good examples of how that works, but it's not been developed to its full. And with the NHS taking on a prevention role under the long-term plan, it's even more important that that coordination be improved. And strong relationships across health protection and health improvement across all 4 nations of the UK, because whatever we do in England is impacted by what happens elsewhere and vice versa. And that's true not just for health protection, but also health improvement. I'll talk a little bit about the tobacco control example, because I think tobacco control is an example of a success story. You know, prevalence has declined by 60% since 2000, when the first specific tobacco control strategy was published with very specific measures, ambitions, targets for reduction in smoking. And that success was driven by combining national population level interventions, for example, smoke-free legislation, increased taxation, a complete ban on advertising, promotion and sponsorship, supported by place-based interventions by local authorities, which are most effective when they are supported by these regional programmes. And the North East is a very good example. It's had a regional tobacco control programme in place since 2005, and it's the one area where we've seen not just reductions in population level smoking, but also reductions in inequality between professional and managerial smoking rates and routine and manual. So regional programmes provide an effective and cost-effective bridge between national and local activity. And that's, you know, tobacco control is an exemplar, but the same would be true in other areas of health improvement. So what are the next steps? Well, the DHSC policy paper was published last week on the 15th of September, and it is still very thin in terms of what it's setting out for what will happen to the health improvement functions. We would urge councils and individual public health professionals to endorse the joint statements, the 2 joint statements, which can be found on the Smoke Free Action Coalition website. If you put in SFAC and joint statements, they will come up. Because we need to stay talking to each other and discussing and agreeing what would be the best outcome for health improvement in all areas, you know, not just smoking, obesity and alcohol, who are represented here, but some of the broader issues around mental health, around sexual health, and there's there's a number of other areas, and we want to make sure that any positions we develop are appropriate for all those areas. There is a high-level options paper due to be published in October, and I think we need to keep working on thinking about what those options should be. There's a stakeholder advisory group, the LGA is represented on it, and a number of the other signatories to the joint statement, such as Mind, the Health Foundation, ADPH, FPH, the Royal Society for Public Health is represented. Our concern is that that group needs to be underpinned by support from the community as a whole. So it's not just, key individuals who are from these organisations, but that they can speak on behalf of the public health community as a whole. I think that is really important going forward. And I don't think the government has thought this through clearly. I think they're very focused, understandably, on coronavirus and health protection. And therefore, it's very important that they get a clear message from those working in public health about what's needed to make the system work in future. Those of you who are around when public health was handed over from the NHS to local government will remember that there was a lot of fragmentation and dislocation, loss of expertise and all sorts of problems. We can't afford for that to happen this time round. We need to make sure that there is a smooth transition from what we have now to what we have in the future, and that we're not just trying to retain what is good in the current system, but actually to improve it going forward. Thank you.
Thank you very much, Deborah. That was really fascinating, and it's interesting you mentioned about the sort of local, and you're absolutely right that I think that if everything was simply just pushed onto local governments, we probably would fall over, in particular because, of course, the funding situation, which again you highlight has been reduced since it came over to local government. So it's got to be that sort of mixture, but I'm sure that there'll be questions about that at the end when we come up. Next, we have Sarah Schoenberger, delivering comprehensive prevention at national, regional and local levels, alcohol. Sarah Schoenberger is Policy and Advocacy Manager for the Alcohol Health Alliance. Sarah is going to talk about the future policies needed at all levels of the public health system to reduce alcohol misuse. Over to you, Sarah.
Thank you. Can you see my screen without
I can see the screen and hear you as well.
Fantastic. Well, good morning, everybody. I'm Sarah Schoenberger from the Alcohol Health Alliance. And before I start talking about preventing alcohol harm, the Alcohol Health Alliance is an alliance of about 55 organizations working together to reduce and prevent alcohol harm. And the membership is quite widely spread, from a lot of Royal Medical Colleges to charities to treatment providers. And for example, the Association of Directors of Public Health is a member as well. So we've already heard a bit about why we need to prevent alcohol harm. And I just want to go into a bit more detail. In England, alcohol has become the leading risk factor for death, health and disability amongst 15 to 49-year-olds. So that's quite a stark factor, but what does it actually mean? If we look at that in a bit more detail, across the UK, there's more than 80 deaths every day that are due to alcohol. So that's more than a double-decker bus every day. In England alone, that also means almost 1.3 million hospital admissions every year. And of course, that comes at a huge cost of about 3.5 billion to the NHS annually. But alcohol harm doesn't just stop at health. It basically affects every part of our society. So it's estimated to cost the economy at least 27 billion every year, but there's estimates that put that figure above 50 billion. It also is a significant contributor to health inequalities. So the most deprived groups are 60% more likely to die from alcohol-related cause than the least deprived groups. And as some of you might be aware, that also plays out across geography. So alcohol-specific mortality is 45% higher in the Northeast than the English average. It also has a big impact on children and families and on crime. So police report that more than half of their time is spent on alcohol-related crime. So especially if we look at the current situation and the pandemic, I think it is clear that alcohol is a big factor that decreases our health. And so doing something to reduce it would not only lead to a more resilient population, but it would also enable us to unleash economic potential and reduce health inequalities. And we've already heard why that is really important, especially in the current situation. So what can we do? Well, there's kind of two parts of it. The first is the population-based prevention measures. So that's kind of trying to stop all of that harm from arising in the first place. And the most effective policies around that are reducing the affordability of alcohol, reducing alcohol marketing, and reducing the availability. But then, of course, we also need to ensure that we've got enough treatment availability for those people who are already at the acute end. And I'm going to look into a bit more detail on some of these, starting with treatment availability, because that's obviously very closely linked to local authorities. Alcohol treatment is very cost effective. So for every pound that you invest, you get three pounds in social return. However, and that won't come as a surprise to anybody, but because of spending cuts that we've seen in past few years, alcohol and drug services typically have seen cuts of around 30% since 2012. And that's kind of led to a situation where only 1 in 5 dependent drinkers are able to get the treatment that they need. Or if you look at it the other way around, 80% of the people who need treatment aren't actually getting it. And that figure is from before COVID. So it is likely that it's going to get worse now, because we know that factors like a recession, job insecurity, bereavement, stress, they are all factors that can lead to people drinking more and at more harmful levels. And Linda already mentioned that there's been studies that harmful drinking has increased since the pandemic. So a plea from me to you really would be like, maintain the investment in alcohol treatment. And I know that's a difficult ask with all the competing interests and priorities. But if we look at how much alcohol just impacts every part of society, and also how cost effective it can be to address it, I think, yeah, it is just really important to keep that investment and not forget about it. But of course, the main aim would be not to need this at all and to prevent all of that happening in the first place. So one way to do that is to reduce the availability of alcohol. So that means like where and when alcohol is being sold. And there's a strong correlation between availability and harm. So for example, there's been a study in Scotland that showed that neighbourhoods with the most alcohol outlets had crime rates that were 4 times higher than neighbourhoods with the least. And there's similar data available for like hospital admissions. And I've got a quote here from Frank de Vocht, from an academic at Bristol University working on the issue. And he's saying that the main way that local authorities in England can reduce the negative impact of alcohol in their area is through the licensing system. And so on a national level, we're working on improving the licensing system and trying to give local authorities more power to control the availability of alcohol in their areas, and also to include public health as a 5th licensing objective, as is currently the case in Scotland, but not in England. However, even within the existing system, like there's some very positive examples of licensing authorities, local authorities that are proactive and that have a licensing policy with a vision to reduce alcohol harm in their local area. And in addition to that, it's important to have like good internal systems to review licenses and refer them to relevant authorities. So while we don't have a public health licensing objective, one that can often be used successfully is the protection of children. So yeah, if you don't have a proactive licensing policy with a vision to reduce alcohol harm, I'd urge you to look at that, because it can make a huge difference. And then another related one are reducing the strength schemes. So those are voluntary schemes between the businesses and off licenses in a certain area, where they agree not to sell specific high strength, very cheap drinks, such as white ciders, because they are like known to cause a lot of harm. And there's some very positive examples across the UK as well, where those schemes have been employed. The 2 other big areas are reducing the affordability and reducing marketing of alcohol. And there's a few different ways to do that. Unfortunately, I don't have time to go into all of them, but do ask me about it at the questions time if it's something you're interested in. The one I want to focus on is minimum unit pricing. So minimum unit pricing sets a floor price below which alcohol cannot be sold. And in Scotland and in Wales, this is currently 50p per unit. And in England, we don't have it yet. The University of Sheffield has done some brilliant modelling work of what the impact of a 50p MUP would be on local areas. So I've got an example here from Blackpool, because it was on the top of the list. And it shows that a 50p MUP would reduce hospital admissions in Blackpool by 338. It would save the NHS in Blackpool £660,000 a year. It would also drive down crime, and it would prevent deaths. And this data is currently available for the North East, the North West, and Yorkshire and the Humber. And what local authorities in these areas have done is kind of use that data to, in the first instance, campaign for a national MUP. So there have been meetings with like the local MPs and other local stakeholders to use the local voice to show why it is important that there's action on a national level. But then also a bit of view to, if it doesn't happen at a national level, looking at whether and how it's possible to introduce it locally. And I think this is a quite good example of how you can use your local voice in national advocacy, because a lot of things are decided at a national level, and so you need to make sure that you've got the local data and you've got like your local voice of why it is important and why it matters to you. And there's different ways obviously to get involved in that. Unfortunately for alcohol, we only have one regional office, which is Balance North East, and they've been doing brilliant work, and they've been driving a lot of the local minimum unit pricing work as well. But there's also local ATPH networks. So, for example, in Yorkshire and the Humber, they have like worked together to set up a local alcohol alliance. And then, of course, there's always us as well, the Alcohol Health Alliance. We work across the UK, and we're always happy to work with new partners, like making sure that we can support people and work together to reduce alcohol harm. Because if anything, like the pandemic has shown us again and again, like why it is important that we need to do that. Thank you. And my contact details are here in case you do want to get in touch.
Thank you very much indeed, Sarah. That was really interesting. And again, you know, sort of highlighting on this prevention side of things, which I think that will be something that hopefully people ask the questions about. And particularly, you know, you're highlighting Blackpool with savings of 660,000 to the NHS. The key question for me always is, how can we forward front that, load that money so we can actually spend that on prevention to find the savings later? But perhaps that's the holy grail we're all looking for. Right, thank you very much indeed. Next we have Caroline Sherney, who's going to talk about delivering comprehensive prevention at national, regional and local levels, this time focusing on obesity. Caroline manages the work of the Obesity Health Alliance. Caroline will be speaking on the action to implement the government's obesity strategy and what more we should be doing to reduce obesity. Thank you. Over to you, Caroline. I think we're onto your Twitter page at the moment. That's better, yes. If we go to slideshow, that would be brilliant. And have you got your mic on mute?
Okay, can everyone hear me?
We can hear you now, that's fantastic. Okay,
great. All right. Hi, everyone. So just a quick word about the Obesity Health Alliance. So similar to the Alcohol Health Alliance, we are a coalition of health charities, medical rural colleges and campaign groups. There's currently 45 members at the moment. And our aim is to influence national policy on healthy weight and obesity, and to try and bring alignment to the sector by speaking with one voice to give a consistent message to government. So we have a policy position that covers 10 priorities that we'd like to see the government introduce to help bring about healthier population level weight. We actively campaign on 3 at any one moment. And at the moment, our 3 policy priorities are protecting children from junk food marketing, enacting an ambitious reformulation programme of food and drinks, and creating healthier retail environments. I'm just going to say a few words about the levels of obesity in the UK. This probably won't be a surprise to anyone. obesity is it's a huge problem in the adult and children population. So currently 2/3 of adults are above a healthy weight. So that means they have a BMI over 25. And of those 2/3, then over half of them will be people who are living with obesity, so having a BMI over 30. It's a problem in children, a growing problem in children as well. So currently 1/3 of children, when they leave primary school, so that's around age 11, they're already at a weight that's classified as overweight or obese. And like we've seen with alcohol, there's a big inequality in rates of obesity. So children in the most deprived parts of the country are twice as likely to be obese as their peers living in the richest areas, and we see that trend replicated in adults as well. So the impact of obesity, we've known obviously for a number of years that living with obesity increases your risk of a number of physical diseases, so type 2 diabetes, several different types of cancer, heart disease, liver disease. People living with obesity are also more likely to have mental health problems, and having mental health problems also increases your risk of living with obesity as well. We found out in the last few months that there's an increased risk of coronavirus complications among people with obesity. They're more likely to be admitted to hospital, they're more likely to be admitted to intensive care, and sadly they're more likely to die from coronavirus as well. And this has helped catalyse the obesity issue up the political agenda in recent months. The costs of obesity are also significant. The NHS spends around £6 billion a year dealing with obesity-related disease, and there's also wider indirect costs, including the impacts on human capital. People with excess weight are less likely to be able to work, and we're seeing now some quite worrying evidence coming through showing that children with excess weight are less likely to do well in exams and then go on to university as well. What's not often talked about as much is the lived experience of people with excess weight. And we've been doing some work around this lately as part of a longer term strategy project, talking to people living with obesity. And they report living with really negative and stigmatizing attitudes towards their weight. In the bottom left-hand corner, this is a quote from one of the participants. People assume that you're eating too much and that you're not exercising. You're lazy and you're a glutton. And then in the top right, one of the participants talked about, I don't do this to myself because I don't care. The narrative around obesity in the media, in the political environment, is very much around personal responsibility. People with obesity are seen to have chosen to live like that. They're choosing to eat badly. They're choosing not to exercise. And what we know from the evidence is that just isn't the case. There can be a genetic predisposition towards obesity, which makes people more likely to gain excess weight and to retain excess weight. But also our environment has changed massively in the last few decades. We haven't suddenly had this massive collective failure of willpower. We live in what we call an obesogenic environment that constantly promotes and markets unhealthy food in large portions and normalises overconsumption and lack of physical activity. So what are we doing about it? Well, as I said, in the last 6 months particularly, there's been a resurgence of interest in obesity, but that reflects a government's interest going back over the last 20 years or so. So the graphs on this slide show how obesity, just obesity, so not overweight as well, just obesity, has increased over the last 20 years or so. So you can see a kind of a steady climb. What these graphs don't show, or what they mask, is the inequality. So I talked about how people from our most deprived communities are much more likely to be obese. And what we've seen, particularly with children, is that our most affluent children, obesity has been reducing, but it's been skyrocketing among our most deprived children. And this has meant childhood obesity in particular has been a government priority. So on the right-hand side, I've listed 22, well, I haven't listed them all, but there have been 22 government or NGO obesity strategies in the last 25 years. And some of these, 5 of them in fact, contain tangible ambitions or targets for obesity reduction. So way back in 1992, the government set an ambition to reduce adult obesity to no more than 6% by the year 2005. Considering adult obesity is now around 27%, and this was only 20 years ago, that seems, like a very long way off to us now. And likewise, there have been, other ambitions to halve the rise in obesity, to halve childhood obesity, to see a downward trend in both adults and children. And then more recently, in 2018, the government set an ambition to halve childhood obesity by 2030, and that's only now a few years away, and I'm not sure that we're doing enough to reach that ambition now. So in the last few years, we've seen a number of national strategies, particularly focused on childhood obesity. Back in 2016, this was the Conservative government's first published plan to address childhood obesity. This was delayed. Lots of policies were going in and out of the strategy. And what was eventually published was very disappointing. And really the only tangible policies that we've seen come out of that strategy have been the soft drinks industry levy, which has been extremely effective at reducing sugar from soft drinks, which we know is children's main contribution of sugar in their diet. And it also launched the sugar reduction programme and the calorie reduction programme, which are voluntary programmes encouraging industry to remove sugar and overall calories from their products. We've only seen data so far from the sugar reduction programme, and it's been extremely disappointing and extremely ineffective. So I think that just is a good pointer of the effects of voluntary programmes compared to regulations such as industry levies. 2 years later, in 2018, we had Chapter 2 of the Childhood Obesity Plan. This was something we were all very interested and excited about in the weight world. It included promises to bring in 9 PM watershed on junk food adverts in particular, and to restrict promotions of unhealthy foods in supermarkets. We only ever got as far as the consultation stage in those policies, and then it all ground to a halt as government changed and Brexit came to the fore. And then a year later, we had Chapter 3 of the Childhood Obesity Plan published as part of the Prevention Green Paper. And this, again, promised more consultations on things like labelling, and then brought in an announcement that the government would be banning energy drinks. But again, we're yet to see that happen. So in July of this year, the government published a national strategy on obesity that was aimed at empowering adults and children to live healthier lives. So this was the first time that this government actually explicitly said that the strategy was to bring about change in adults as well. Previously, the government had always used the lens of childhood obesity because that made it more politically palatable, I think, to be seen to be bringing in policies that influence what people eat. This strategy was in direct response to the data showing that coronavirus was having much more of a marked negative impact on people living with obesity. And what the government wanted to do with the strategy was to bring in a number of policies and campaigns that they think could help and encourage people to address their weight or take steps towards addressing their weight in anticipation of the second wave of coronavirus. So we saw a better health campaign. So this is the social marketing above the line campaign, squarely aimed at people living with overweight rather than more at the extreme end of the scale of obesity. And you've probably seen lots of adverts and see them on TV and out and about. It's encouraging people to download the 12-week weight loss app from the NHS. The strategy has promised an expansion of weight management services, which is much needed because we know in some areas people can't access Tier 3 and Tier 4 services in particular. But there was no detail on how this would be done. We know that funding is going to be the key to unlocking further weight management services, but nothing was said about that. They also launched a front of pack labelling consultation. So they're asking for views on the current traffic light system and also consulting on systems used by other countries, such as the black warning labels that Chile brought in recently. And they've also promised to introduce calorie labelling on menus in the out-of-home sector, but they've limited this rather disappointingly to large outlets only, which means it will only cover about 5% of all out-of-home outlets, and not the smaller cafes and takeaways, which we know are part of the problem, particularly in more deprived areas. The strategy also included consultations on calorie labelling on alcohol, which was a bit of a surprise, but something we're very supportive of, particularly for helping adults understand quite how calorific the drinks they're drinking are. And then it also promised legislation on multi-buy location promotions by the end of 2022. This was something they consulted on back in 2018, and we've seen no movement on. So while we're very pleased that there will be some movement on this, 2022 is a long way away, and it will be a 4-year gap before they actually do something they said they would do. And likewise, there's the promise to bring in legislation on junk food advertising on TV and online also by the end of 2022, which is again a long time away. And interestingly, a short consultation on whether we should have a total ban on unhealthy food and drink advertising online. So we're expecting to see this launch in the next few weeks. So I wanted to say a few words about local work. It's not something that OHA focuses on. Our focus is very much on influencing national obesity policy, but I wanted to signpost a few pieces of work which are ongoing around the UK. So the Trailblazers programme was a funding programme from the Department of Health that was launched as part of the 2018 obesity strategy, and it aims to fund tests of innovative approaches in different local authorities, so different ways to tackle obesity. So 5 councils have got funding, and these projects are all underway, all looking at different ground level different campaigns and approaches, and you can find out more about them on the LGA website. The whole systems approach document is a guidance document from Public Health England, the LGA, and the Association of Directors of Public Health, and this is aims to be a bit of a how-to document to help local authorities create their own whole systems approach to reducing obesity and promoting healthy weight, and that's on the government website. And then one of our members, Food Active, provides support for local authorities to make a healthy weight declaration. So this is been adopted by 23 local authorities across England, and it comprises of 6 ambitious but achievable commitments to help bring together policy and practice across local authorities. And you can find out more by contacting Food Active, who are based up in the Northwest. So what next? Well, this was the line from the government's 2020 obesity strategy. We're under no illusions that further measures are needed. So they know that not enough is being done, and they keep telling us that this is the start of the conversation, and we will hope to see more kind of happening over the next few months. So in particular, we'd like to see much more on treatment and support, making sure that equitable evidence-based treatment is available for those who need it, and that includes psychological support as well. There's much more that needs to be done on reformulation. As I mentioned, the sugar reduction programme is failing. We'd like to see much more on infant food in particular as well, to address the high sugar content of baby food and some of the unethical practices around marketing in this area as well. The government's also alluded to more work with employers to help employers provide supportive programmes for people in work, and also global action. So this is something that's increasingly starting to get attention. So many of the food companies that dominate the food that we eat are global companies. There's really only a handful of food companies at a global level that are responsible for all the brands of food that we see, and things like reformulation might be much more effective if they were aligned globally, and there'd be more of an incentive for companies to take action. So I think it's early days. I think this is the closest we've been to having some hopefully effective population level, structural level policies. The government, has made these commitments to bring in things by 2022 and go further. I think I always equate this government's action on obesity to a bit like kind of waves. We're seeing waves of different strategies, and each wave takes us a bit further towards the shore. It's a slow process, and suddenly we can see that the moon changes and the tide goes out again, and that's very much the case of obesity. It's very much top of the political agenda at the moment. So we're hoping to get as much done as we can while that lasts, but we're under no illusions that all could change with a change in personnel, particularly at the top. So often it's a case of 2 steps forward and one step back, but hopefully it's something that we'd like to make progress on in the next 2 years.
Okay, thank you very much indeed, Caroline. That's really fascinating. And of course, you mentioned the advertising and everything, and it's the 2-for-1 measures that is, when are we going to have the 1 for 2 or something in reverse? I don't see it could never be a marketing ploy, but that's the thing to actually encourage people there. Right. Okay, now we have Hazel Cheeseman delivering comprehensive prevention at national, regional, local levels, focusing on tobacco. Hazel Cheeseman is Director of Policy at ASH and manages the delivery of ASH's grant work for the Department of Health and Social Care. Hazel will be speaking on the action needed at local, regional and national levels to deliver the reductions in smoking needed to achieve the ambitions of a smoke-free England by 2030. And I should just say that Oxfordshire's ambition is by 2025 to try and push ourselves a little bit along. Anyway, don't forget the questions for later on. Over to you, Hazel.
Thanks, Ian, and thank you as well for really leading the way in local government, not only in Oxfordshire, but also within the LGA as well. So yes, I'll just reiterate Ian's point around adding questions to the question tab, as mine is the last presentation before the Q&A. Okay, so I'm going to whip through these slides so we have lots of time for questions. So I'm talking about comprehensive tobacco control, and it's not unreasonable to ask the question, what is comprehensive tobacco control? And that is something very clearly laid out. We have an international treaty on tobacco, which, among other things, requires government to protect tobacco policies from the commercial and vested interests of the tobacco industry. And there are also a well-established set of policy actions set out here, under which we consider to be comprehensive tobacco control to be delivered. And all of these have functions that can be done at local, regional and national level, and it's necessary for all of those actions to happen at local, regional and national level. So I won't go into a lot of detail here, but you can look up the Empower stuff, and many of you will already be familiar with that, I'm sure. So Deborah already talked about the success of tobacco in the UK and the fact that we're really leading the world in many regards. So this compares smoking prevalence in the UK with smoking prevalence in the EU, and you can see the blue bar there that we have over time declined faster than the European average on smoking rates. And that's not happened by accident. It's happened because we've applied this comprehensive approach to tobacco control through national strategy, through regional action, and through effective local delivery. And my next slide is a little busy, but it kind of gives you the idea about the many different interventions that have been put in place over time and seen smoking rates fall as a consequence. So various highlighted here are kind of key public health measures that have helped drive smoking prevalence down over time. So many of the things set out on this slide are, in fact, all of them, I think, are national kind of legislative actions, but they have been backed by the actions and strategic and policy delivery that's happened at other levels of the system. So it isn't an either or, it is about doing these things in concert. I'm going to move on to just talk a little bit about the impact that COVID is having on tobacco control, because I think this is really key for how we think about rebuilding services and our delivery and rethinking our services and delivery following the impact of COVID. So these are sort of very, these impressions I think will change over time, but these are sort of some initial impressions from Ash about what the impact of COVID has been. So clearly there's been a big impact on service delivery. Things have moved online very rapidly, and services have done an absolutely fantastic job at local level of reorientating what they do and continuing to provide a service in a socially distanced way that has been extremely impressive. But there have been other impacts on service delivery which have perhaps been less positive. So we've, because of the need to invest in national campaigns on other issues, particularly in relation to COVID, we have seen a decline during this month, in October, or this month coming, it's the 1st of October today, yes, on national mass media. We have a reduced capacity there around encouraging people to quit, and that seems likely to continue. Clearly the delivery within the NHS has been impacted, even at a time when there's a greater need to protect NHS capacity, and we know that reducing smoking rates can be really important to achieving that. And also COVID has had an impact on smokers. We have the research that we've done using the YouGov COVID tracker and working with colleagues at UCL indicates that there really has been increased quitting behaviour and increase in quit success during COVID. It does appear to have been a teachable moment for smokers to change their behaviour. But there's also evidence that smoking behaviour is quite volatile, particularly among younger adults. Some of the evidence from the COVID track appears to be indicating that smoking rates among younger adults might have increased since lockdown eased, and certainly data from the UCL smoking toolkit is showing quite a bit of volatility in young adult smoking behaviour, and that's something that we really need to kind of get a handle on, in how we're going to support those young people to either remain quit where they have successfully quit, or to make a quit attempt where they have relapsed or started smoking. And it's we don't know why there's this volatility in young adults smoking behaviour, but my guess would be that their lives are pretty volatile right now as we move in and out of lockdown, and their lives being so impacted by those changes is impacting on their smoking behaviour. And I think there's some big questions to ask about, what impact further lockdown measures might have on people's smoking behaviour. Will we see the pattern of it being a teachable moment continue, or will that change? And then, of course, the recession and the economic consequences and what impacts that has on people's behaviours. So I think all of that taken together, addressing smoking as the leading cause of preventable ill health has always been important. But even more so now, it's a key factor in reducing pressure on the health service. Getting everybody to have their flu jabs is an extremely important measure, and then probably smoking cessation following that in terms of reducing impact on NHS services through the winter. It is a big driver for health inequality, and health inequalities have seemed likely to have deepened as a result of COVID-19. So if we're going to get on top of that going forward, we really need to make sure we're getting on top of smoking prevalence. Addressing smoking can help support economic growth and prosperity. Last week, Ash published a new report looking at the impact on smokers' income and employment prospects, showing, collectively the loss of income for smokers across the country each year is in excess of £14 billion in reduced earnings and being unemployed. So, addressing smoking prevalence can really contribute to local economic growth. And as I said, lockdown has had real unpredictable impact on behaviours, and we're going to need local strategies to prevent any rise in smoking behaviour and to capitalise on any decreases as well. So just a quick note then on what some of the activity might be to bring smoking rates down further and achieve the government's vision of a smoke-free 2030. So we'd certainly need to continue national action if we're going to achieve this ambition. Ash in January published a roadmap to smoke-free 2030, which has been very widely signed up to. And that the kind of flagship policy in that roadmap is a levy on big tobacco as a means of raising the funds that we need to tackle smoking nationally, regionally, and importantly, locally. And it also calls for consultation on a range of measures, and I've set out a couple of those there. So licensing for tobacco retailers is something that we feel is long overdue. Raising the age of sale from 18 to 21 is something that we think warrants further exploration, given the impact that raising the age of sale from 16 to 18 had on young smoking behaviour. And there are also some other measures in there, for example, inserting kind of health warning information into packs, which we think the government could easily do in a kind of fairly cost-free way and have an impact on smoking rates. There's much more in that roadmap, and I put the link on the slide there, which will be circulated afterwards, and encourage your organisation, if they haven't already, to sign up to it, but certainly to have a look at all of the recommendations in that report. We've already talked in Deborah's presentation and elsewhere about the importance of regional action, but I'll just reinforce that where we have had comprehensive regional programmes, we see rates of decline in smoking exceed that of the national average, and they've been particularly successful in tackling inequalities and bringing rates of smoking down among routine and manual groups quicker than other populations. And programmes like illicit tobacco and mass media campaigns are very effectively done at the regional level. And they've also had an important role coordinating across geographical areas and bringing different stakeholders together. So that regional tier remains extremely important going forward. I also wanted to think, as we think about local strategies going forward, about how we can learn the lessons, build on some of the lessons from COVID-19, because there certainly has been, some really great things done over the last few months in some extremely difficult circumstances. So there's been some really innovative local communications campaigns. I've got the images here are from Sheffield and the work that they did during lockdown, communicating to people who were shielding about how the benefits of quitting smoking. They had stickers on boxes of stuff that were going to people and leaflets, and they did a range of other things as well. And there's been a number of local authorities who have really kind of got the wind behind their sail in terms of doing local communications work, and that's been very effective. And Usher supported that as well through our various Quit for COVID campaigns, which webinars are available elsewhere, and we can circulate with the information from this webinar. Also, we have put in place some new service models across the board, because we've had to move to remote working. And there has been some advantages of moving online or over the phone in reaching smokers in different ways, of being able to do things to a larger group of people, perhaps, than when services are face-to-face. That's not to say that we should throw the face-to-face service out with the bathwater. But clearly there are things to be learnt from the way that services have been operating over the last few months, and holding on to the kind of good parts of that as we move forward is something that Ash is keen to see happen. COVID has also seen local authorities, I think, reach out to new populations which they might have found more difficult to reach out to in the past. So I'm particularly here thinking about homeless populations, people that have been housed in hotels and other settings, that local authorities have reached out to and provided services to in a way that perhaps hasn't happened in the past, and thinking about how those relationships can be sustained going forward is a real opportunity. And there's also been a big discussion around smoke-free places. There was a discussion around pavement licensing, and whether these new pavement licenses that were being granted as a result of COVID should be smoke-free. And many local authorities have decided to adopt smoke-free pavement licenses through their own choices. But there has been all sorts of debates around where smoking is appropriate. As people are queuing up to go into supermarkets and in other environments where smoking has become an annoyance to others. I think that's an interesting discussion to continue going forward. But there are also things that we need to protect and rebuild that have been perhaps a bit impaired by the impact of COVID. So we know that many areas have found it really difficult to sustain their tobacco alliances during this time, with local authorities under such a stretch. I will commend to you the resource that's on the ASH website, this local alliance roadmap, which, as we move forward, getting local alliances back together and figuring out how to make them a success through 2021 will be a really important priority for many local authorities, and we hope to have a webinar specifically about that in the future. VBA, very brief advice, has probably fallen by the wayside in many services. People have been focusing on other priorities, but getting services back on track at encouraging people to talk to their client groups about their smoking and direct them to the support that's available. That will be an important thing to think about going forward. Enforcement of tobacco regulations, enforcement services, like many services, have been really stretched during this time. It seems likely that some of the tobacco regulatory side may have taken a backseat. So how can we re-energise our enforcement functions to kind of get back on that as we look to recover in the coming year? And also coordination with the NHS. All services are flat out and stretched right now. As and when it's appropriate, we really need to make sure we can get back coordinating with the NHS, local government coordinating with the NHS. And we also have the rollout of the NHS long-term plan and the tobacco components of that to look forward to going forward. And we need to make sure we can capitalise on that. So that's the end of my presentation. I'm just going to point you to a couple of other additional resources that I hope will be useful in the development of local strategies. Ash has just so much information on the local tab of our website that you can use to think about local strategies and the impact of smoking locally. So I encourage people to go and explore the various resources that are there. And we also have this document published, so much has happened this year. I can't recall if it was at the beginning of this year or the end of last year. I think the beginning of this year, the end of smoking, a strategic document that is about setting local strategy. And I think using this document alongside thinking about what the impact of COVID will hopefully be a really useful starting point for local authorities in thinking about your future tobacco control strategy as we look hopefully towards recovery at some point in 2021. And I will stop there.
Thank you very much indeed, Hazel. And if I could ask all of the panelists and presenters to switch back on their video, and perhaps we can have the question and answer session sharing around. And I think that's, if Hazel, if you could drop down your screen so we don't share anymore, so we can actually go around. That was really good. We've got about 20 minutes or so that we've got some questions to go on. As always, it's one of the privileges of being the chair is you can ask the first question. And everybody mentioned inequalities, which is just a theme running throughout. And it also, I think, impacts on the fact that are there multiple issues for the same people. But inequalities for me in Oxfordshire is particularly important because I think everybody's impression is that it's a green open countryside, everybody's very healthy, and we've all got degrees, which I haven't, by the way, and we're all super rich, etc. But of course we actually do have some of the really poor areas, deprived areas, and there's one ward that's just 4 miles from another ward in Oxford. There's a 15-year life expectancy difference, and that to me really is where it gets down to the locality, and that's where my passion for localism comes, because otherwise everybody ignores Oxfordshire because so it is. So I don't know whether anybody's got any thoughts on that. They'd like to speak up. Hazel? Yeah.
Yeah, I mean, addressing health inequalities is, I think, the key here. What I think from all of our presentations, the gap in healthy life expectancy has been going in the wrong direction, and how local strategies can focus in on that. We need to do actions at national level as well as regional, but local strategies can really help to amplify that. And I think some of the interesting stuff that has been done over, through lockdown, over COVID, targeting those particularly at need populations, has really been very illuminating about what can be achieved. I think working with homeless populations is something that many services might have thought about or aspired to do over time, but maybe thought it was a bit difficult. But getting in there and discovering that you can get people to change their behaviour, I think has been very, rewarding.
Just to add to that, Ian, so if you look globally, I know we talk about the countries that have done well during the pandemic, obviously not leaving aside Southeast Asia, Taiwan, who've learned from the past, but all this discussion about Scandinavia, the main reasons why Scandinavia have done well, Norway and Finland in particular, but to a lesser extent Denmark and Sweden, is because of the way their societies are organized. 50% of people in Sweden live alone, they have adequate housing, they have good social security. So I think a narrative around reducing inequalities as a way to prepare us for not suffering so badly in the next time we face this kind of crisis absolutely has to be part of the discussion. And I think one of the slides I showed in my presentation just about how big a threat ongoing inequality is compared to the immediate threat is useful. So hopefully we can build on that narrative and just choose the things that you want to do locally and in your patch that you think will be effective based on the evidence. I think that's all we can do, but you make such an important point.
Thank you. Deborah, I think you're on mute. No, you're still on mute, Deborah.
I muted you, Deborah.
Right.
Oh. Try
Says
now.
I'm muted. Can people hear me now?
Yes.
Good. Okay. Yes, I grew up in Buckinghamshire, and my father worked in Oxford for some time, and I also worked in the car industry. So I completely get where you're coming from. If you look at Cowley and the impact of what happened to the car industry on that area, just because it's Oxfordshire and it's leafy and all the rest of it doesn't mean there's not a lot of inequality there. And I think one of the things that always struck me when I first came into tobacco control was that people talked about hard to reach populations. And what we've tried to focus on is that they're not hard to reach. We know where they are. Actually, you need to go out to where those populations are. And that's why the place-based approach is so important. And some of the work we've been doing on, for example, smoking rates in social housing and in the rented sector, there's some really good initiatives there that have happened, for example, in Salford, where housing associations provided electronic cigarettes to smokers in their housing with very high success rates. So I think you make a really important point, and there is some geographical distribution, but that doesn't mean that communities like yours don't have inequalities, and those inequalities are linked to housing, they're linked to socioeconomic status, all these other things. And I think we need to do better at actually reaching those people where they are.
Okay, thank you very much. I've got a question which might be quite large, the answer. How are you utilising, or perhaps if we could just mute while we're not actually speaking, utilise the ambitions of the NHS long-term plan and the integrated care systems to support this agenda? Like, crikey, we could spend all day talking about this, but can anybody very quickly, come in on this? Oh, Linda, are you signaling to speak on that?
I was trying to gesticulate towards Hazel because she and I were discussing this just the other day.
Oh, right, okay.
Something
Hazel,
specific I said that you thought I ought to repeat, Linda?
Just what an important mechanism that is, but back to you.
Yeah, I mean, clearly the NHS delivery is going to be, is important to all the things that we've been discussing, and has been impaired by the need to respond to the COVID-19 pandemic. The coordination between NHS and local government is absolutely key, because public health responsibilities in many regards remain with local government, and the integrated care model therefore creates opportunities for some of that coordination, but is not, I think, we would say, a substitution for local government leadership. NHS long-term plan has a range of commitments that relate not just to tobacco, but and I couldn't speak to the ones that relate to obesity and alcohol because I'm not so familiar with them. And the rollout of those is going to be on tobacco really important because they are evidence-based measures which should reach the at-need populations that we've been talking about, who are sick and need interventions to help tackle their smoking. I had a really interesting conversation with the College of Podiatry on Friday, and they are reaching a population of people who are at risk of having their limbs amputated because they've got ulcers as a result of diabetes. They are having ad hoc conversations with their client group about smoking, but we know that where people who are in that position don't quit smoking, they are much more likely to go on to receive amputations. And the investment and the opportunity to coordinate around that is significant, and to engage the NHS to link the relationship podiatrists up with local service delivery is really there, but maybe not quite happening. And that's back to your point, Ian, about the opportunity around, or the need to focus around inequalities. This is a population of people who are experiencing probably multiple indicators of disadvantage. So that coordination between NHS activity and local government activity and public health, just by that one illustration around people coming into podiatry with foot ulcers, just illustrates where the opportunities are that need to be taken advantage of if we're going to build recovery across the NHS and local government going forward. Was there anything else I said when we talked about it, Linda, that you thought was worth repeating?
No, I mean, I'm just thinking across alcohol, tobacco and food, and clearly the commitments in the plan around prevention are not as specific as they should have been, but the opportunity to intervene, particularly with briefer interventions in the NHS, and then also referral to resources or services that need to be well resourced. So Caroline, in talking about the plan, there is that commitment to weight management services. We've heard from Sarah about the disinvestment in alcohol treatment. These are all things that need to be embedded and connected to the NHS long-term plan, because they are health interventions, so NHS interventions, even if they're run by others outside of the NHS. So I don't know whether that's a helpful comment as well.
Okay, thank you very much. Another question we have: is there a risk in trying the importance of addressing obesity or health issues to coronavirus? And once COVID is less of an acute, is that a risk? But I think we're all sitting here probably wondering, when's it going to be less of a acute? But I mean, we can see that tying it in at the moment, is that something that we've got to consider as well?
Well, I think that's a really interesting question. It's something we've been talking about a lot because we've been trying to get movement on obesity policy, for a number of years now, and it's really interesting to see how the very acute risk of the speeding train of coronavirus has been much more of a catalyst than the much longer term, but equally damaging. And when it comes to mortality and morbidity, diabetes and cancer are probably bigger than the acute coronavirus risk. So it's interesting how that I think probably the Prime Minister becoming ill from coronavirus was a very big catalyst. And so I think what we're trying to do now is make sure that we're not framing this new strategy and these new policies as being just in response to coronavirus. It's very much about addressing the much longer term risks of living with obesity. I think for people living with obesity as well, it can be very scary to talk about, just be talking about the increased risk of coronavirus as well. So we're mindful of that.
Yeah, certainly. Hazel.
I obviously don't have an awful lot to contribute in relation to obesity, but I think all of the issues that we've been talking about today, tobacco, alcohol and obesity, they all will play into the recovery from COVID, both on the health and the economic side. And it's why we're having this event today, and it's why it's called what it's called, is that while one can hope that the kind of acute phase of the pandemic will pass at some point, there will be a longer term impact from the measures that we've needed to take to respond to that pandemic, and addressing tobacco, alcohol and obesity can support the recovery that we need to put in place following that. And the as much on the economic side as on the health side, or also on the economic side as well as the health side.
I think absolutely, because I think that's one of the key things about it, because lockdown projects perhaps should have been to reduce weight or to reduce alcohol or to give up smoking. Unfortunately, I think it's the reverse has happened, but at least now coming out of it, there is that sort of admission by people that I have put on weight, or I have drank too much, or I have smoked too much, so therefore coming down. Linda, you wanted to add something there.
Yeah, I wanted to add a broader point. I think actually we should exploit this. I think the advantages far outweigh the disadvantages. So in terms of how we behaviorally respond to threat, we respond to immediate threat. We're kind of hardwired as humans to be afraid of infectious disease. That's the case for centuries. And that's going to continue. So we need to use that to raise the other issues. As Caroline says, now obesity is in the spotlight. Let's do everything we can to make sure that it continues to. But those of us speaking about it publicly are very clear, and locally as well, Ian, that the narrative is not about the infectious disease. It's about the fact that this is an opportunity to raise the longer term threats, which we don't respond to in the same way as humans. And actually from the tobacco side, e-cigarettes are a really good example of that. The press, not anymore, but in the past were obsessed with talking about vaping, and it gave us an opportunity to keep bringing it back to core tobacco control. We haven't tackled smoking, let's focus on that. So I think the advantages of having this opportunity probably outweigh the advantages if we frame it in the right way.
Okay, thank you. Another question we sort of touched on a little bit. How can councils better address health improvement for local public health teams to work with to reduce those obesity, alcohol, improvements through other functions of the council, for instance, housing or licensing, and actually as well leisure facilities and just the well-being for libraries as well? Is anybody going to pick up on that one?
Sarah, do you want to speak on licensing? That's a good example.
Can you hear me?
Yes.
Okay, perfect. Yeah, I guess I already ran through it in the presentation, but for alcohol, licensing does play a huge role, and so I guess making sure that you've got a public health voice within the licensing process, even though it's not an objective, but making sure you're connected to those colleagues and that are working with it, making sure they see the public health side of it, and don't just see it as a business opportunity, which of course at the moment is really important, and we've got a really struggling hospitality sector, but also making aware people are aware of those other consequences. And I guess it's not just health, but it's also the crime impact, and taking all of that together, because I think too often it can just be very easily, oh yeah, of course, we grant this license, without considering any of these other factors.
Would that mean that you might sort of consider that public health be an actual one of the licensing objectives? Because at the moment we've obviously got public nuisance, we've got the harm to children, but it should be expanded a bit there.
Yeah, exactly. Yeah, so we've got that in Scotland already, and so on a national level we've been campaigning for changing the licensing regulation to get public health included, because it makes it just that much easier. But I guess as long as we don't have that yet, there's other ways to bring in the conversation, and so one way is through the licensing objective of protecting children, because you can make an argument, oh well, it's next to the school, kids should be protected from seeing alcohol being sold all day, and the fights that might break out.
Okay, Deborah, you put your hand up very quickly there. You were.
Yeah, I was just going to say that Ash has a lot of resources on how local authorities can take action at local level. And just thinking about what Sarah was saying, we've got a local toolkit. Have you produced a local toolkit for local authorities on licensing and alcohol and what they can be doing? Because that might be a useful resource if you haven't done it already.
Yes, I don't think we've got anything up to date, but there's definitely, like, yeah, I can look into that, and I'm sure like some of the partner organizations have done some work on that, and there's some really good examples from like some councils who've like used very innovative approaches and like collected a lot of data on kind of how alcohol availability impacts on specific areas, and not just like the whole area, but like just on the street level, for example. And they've been saying like how important it is to have that local data to be able to make the representation.
Yeah. Well, all I'd say is that from our experience, local authorities are very stretched, and the more you can provide them in toolkits and case studies about what they can do, the more authorities that aren't currently engaged can do to do stuff in this area. Because, you know, with the funding cuts local authorities have received and the cuts in public health budget, the easier you can make it for them, the more likely they are to do things.
Thank you very much indeed, Deborah, for that plug. I think that that's something that, you know, local authorities, well, we know that public health, for instance, in 2013, 700 million pounds has gone. You know, just what could we have done from that if we'd had that additional 700 million pounds? And I mentioned earlier about how can we make the case to get some preventative funding out of the money we're going to save in the future. But I think we've only got a couple of minutes left, so I'd just like to thank Hazel, Linda, Caroline, Sarah and Deborah. Really good. It's really been thoughtful. Thank you to everybody who's joined in as well, and the questions. I'm sorry we didn't get through all the questions, but as always, we always have the problem of hitting the clock. But I think that it's highlighted to me the conversations today about inequalities, about the fact that we've got to really target our resources rather than sort of broad across there, and that's on everything, on all areas as well. And funding, yes, it does always come up, but I mean, that is the issue, that if we've got the funds, we can do it. We all know prevention works, and I can assure you, in my position as a leader of a council, that I've taken about 400 million pounds out of Oxfordshire's budget since 2012. It's been really difficult decisions. I know that some of those decisions, you know, personally, I didn't come into politics for them, but I have to balance the books. And so those sort of the additional funding, if we could have that. And then, of course, this link between the NHS and local government, which we've seen some extraordinary work over the COVID issues, and how can we actually enhance that to make sure that the NHS does look at the prevention agenda, because again, everybody knows about prevention, and I think in all the cases, prevention is far better than curing the risk, because of course that is the real thing. If people don't start smoking, if they don't drink too much, if they don't overeat and become obese, then of course it's far easier. So I think that's really been a really good morning. Thank you once again to all our presenters, and thank you to everybody, and see you all soon. Thank you very much. Bye bye.
Thank you.